Okay, I took a few days off from studying, but I'm back on hopefully to finish ECG and lab values. So let me go ahead and skip on down to where I was. Here we go. So these were the tachyarrhythmias in the from figure 13-14 in the O'Sullivan book. So we did all the tachyarrhythmias that are highlighted: atrial fib, atrial flutter, SVT, and VTs on the previous recording. Now this one is going to be on examples of ectopy and arrhythmias. We're going to focus on PACs in this video and then move on to PVCs and be done with this particular study. So let's start with a PAC, known as a premature atrial contraction. So I already pulled up a pretty cool video.
Premature atrial contractions, PACs, are premature heartbeats originating in one of the upper chambers of the heart, the atria. PACs are common among patients with lung disorders, such as chronic obstructive pulmonary disease, COPD, but they also often occur in healthy people. PACs may be caused or worsened by caffeine, alcohol use, and certain medications. Apart from occasional palpitations, PACs are generally asymptomatic and do not require treatment in otherwise healthy people. A PAC happens when the atria are activated by an ectopic site in an atrium instead of the SA node. Because atrial depolarization is initiated outside the SA node, the associated P wave has an unusual, non-sinus morphology. An early atrial activation may cause the P wave to merge with the preceding T wave, producing a peaked fusion wave. In situations where the ectopic site is located near the AV node, the atria are depolarized, mainly by retrograde conduction, and the resulting P wave is inverted. The PR interval representing the time the signal reaches the AV node is slightly shorter. An ectopic atrial activation can usually enter the SA node, depolarize it, and reset its timing, causing a so-called non-compensatory pause. On an ECG, this is seen as changes in the PP intervals that contain the ectopic beats. This feature can be used to differentiate PACs from ectopic beats of ventricular origin, PVCs. PVCs typically do not conduct back to the atria. SA node firing is not affected, and PP interval remains unchanged. The downstream ventricular conduction of a PAC can be normal, aberrant, or absent. In most cases, conduction through the AV node and ventricles is not affected, resulting in a normal, narrow QRS complex. Occasionally, however, ventricular conduction may be aberrant, causing a widened QRS complex, usually with right bundle branch block morphology, which may look similar to a premature beat of ventricular origin. In this case, differentiation is made based on the presence of a preceding P wave and a non-compensatory pause in PAC. A non-conducted PAC is one that arrives too early to the AV node, at the time when the AV node is still in refractory period and thus cannot be activated.
Whenever we're describing or whenever we're interpreting ectopic beats and interpreting the rhythm in that context, it's important to always interpret the underlying rhythm first, followed by the heart rate, then followed by the ectopic beats, in this case premature atrial complexes. So in this case, the heart rate the underlying rhythm may vary. Maybe normal, maybe slow, maybe fast. It just depends. And in order for the premature beat to be called a premature atrial complex, it has to be an upright P wave. So this is what we're looking for. And in this case, here is a sinus beat. Here is another sinus beat. Here's another one. And here is the premature atrial complex. And you'll notice that, well, first and foremost, it comes earlier than the next expected beat. And secondly, the P wave morphology is also different from the underlying P wave morphology. So those are some indications that this is a premature atrial complex. The remaining beats all appear to be sinus. So this is sinus beat, and so on and so forth. So we look at the underlying rhythm and it appears to be sinus in origin. The heart rate here is, well, we'll take this one, which falls in the dark complex. The heart rate is 300, 150, 100, 75. So we have a sinus rhythm of 75 with a premature atrial complex. The PR interval is generally normal or maybe prolonged. The QRS is usually narrow. The ratio is 1:1. And the underlying rhythm is regular except where it's disrupted by a premature beat. So what we want to know then when we're assessing a patient and documenting what we see on the ECG is what's the underlying rhythm, what's the heart rate, what is the ectopic beat, and how often do they occur. So are we seeing just occasional PACs? Are we seeing frequent PACs? Are we seeing, or do we want to give it a number? Do we see, 10 to 12 PACs per minute or 6 to 8 PACs per minute? So that's essentially how we want to document that. Here are some examples of premature junctional complexes. So here we have a normal P wave and QRS, normal P wave and QRS, normal P wave QRS, normal P wave QRS, normal P wave QRS. Are you still with me? Normal P wave QRS. And here we have an inverted P wave and a QRS. So you'll notice if you look at the RR interval here, this next one with the inverted P wave happens earlier than
the rate and rhythm for these following rhythm strips here that we have before you. Okay, these are going to be basically premature atrial contractions. We also call them PACs. So I kind of want to just give you guys a little kind of info about what PACs are. So again, you guys know that in the heart, right, we have this structure here in the right atrium called the SA node, right? So this would be our SA node. Then you guys know over here, kind of right around the top of the interventricular septum, you have your AV node. Then you have your bundle of His. And then after that, we have your right bundle branch and your left bundle branch, right? Now, generally the SA node is the pacemaker of the heart. He sends the action potentials to the AV node, right? And it's at a specific rate, right? So we kind of want it to be every about 60 to 80 beats per minute. And it's a specific rate that it keeps it at. Sometimes, basically, whenever this little focus here, this little ectopic focus becomes agitated for some reason. What are some reasons that this little ectopic focus or this little irritated atrial tissue can become such irritated in the way that it starts sending out its own action potentials? Well, these ectopic foci can be triggered by a couple different things. One is hypoxia. So whenever somebody has low oxygen within the blood, and there can be many reasons for this. It could be because of COPD. It could be because they have pneumonia. It could be because they have some type of pneumothorax. It could be because they have less red blood cells, so they have anemia. There could be a thrombus with going to the pulmonary arteries or an embolus. So there's many different reasons that they can have hypoxia, but whenever there is hypoxia, these tissue cells become super agitated and they start sending out action potentials. Okay, and sometimes faster than the SA node, and it beats the SA node before the SA node can get its action potentials to the AV node. These action potentials from this little ectopic focus gets to the AV node quicker. All right, what are some other reasons? It could be due to electrolyte abnormalities. So sometimes in situations where there's changes in potassium, so maybe hypokalemia, it could be due because of someone has excess catecholamines. Okay, so in other words, an increase in your epinephrine or an increase in the norepinephrine. So these could be certain things as well. And there's other situations. It could be, other things could be, maybe stimulants. So cocaine, methamphetamine. A lot of these things can basically agitate these atrial cells and trigger them to fire before the SA node fires. Now, because it fires faster than the SA node, it also is going to have another thing. So here's one thing I want you to remember. It fires before SA node, okay? And it looks different than SA node's P wave. Okay, so whenever the SA node does fire, it has a specific P wave structure. These PACs that are coming from these ectopic foci, they're going to look different. So let's go to this top EKG here where we're looking at lead 2, this rhythm strip. Okay, and let's kind of do the first thing that we do, rate. How do we determine the rate? Again, you can determine this by, okay, there's 1, 2, 3, 4, 5, 6 seconds. On this rhythm strip, you multiply the number of R waves by 10. So we have 1, 2, 3, 4, 5, 6, 7, 8. 8 times 10 is going to be 80. So this is moving at about a pace of 80 beats per minute. Okay? Next thing we determine, rhythm. So R to R interval. Okay, well this is interesting. Look, this kind of has like a 1, 2, and about like a half over here. Then it goes 1, 2, 3, 4. This is definitely irregular, right guys? So 1, 2, 3, and about a half over here. And again, maybe about a half here. 1, 2, 3, and then again I go 1, 2, 3, 4. This is definitely irregular because then I go 1, 2. So I definitely have not consistent R to R interval spaces. So this is definitely irregular. Okay. So this is an irregular rhythm. Remember I told you that there's pretty much not that many irregular rhythms. The main one is going to be AFib. Other ones can be these types of ectopic rhythms like PACs, PVCs, and another one called multifocal atrial tachycardia. So there's not a lot of irregular rhythms. This is one of them. All right, next thing. We determine our P waves. Are the P waves all the same? Do they look the same? Do you have P waves? All right, well, here's have a P wave, and then look at this one. Remember I told you that if it's an ectopic focus, a PAC coming from the atria, it comes earlier than it should. Okay, let's find a P wave that looks just like this one. I'd say this one, these kind of pretty much look the same. They're definitely the same. This one is definitely different from these two. Okay? So because of that, I know that this is a normal one, and this is a normal P wave. And this guy right here is definitely an ectopic focus. Why? One reason, it comes early. Look at the R to R interval here. It's definitely going to be a lot sooner. There's a decreased R to R interval. And what's the other second thing I told you? The P wave looks different. It looks nothing like this first P wave. So definitely, we're going to call this one a PAC. Let's keep moving down. Let's keep ticking away. This is a normal P wave. This one's definitely the same. This one's definitely the same. Again, the same. Oh, there's again another PAC. How do I know? Look at the R to R interval. There's a decreased R to R interval. It came soon. And what else? This P wave right here, it's different. It looks different. There's another PAC. Okay? That's what I want you guys to remember. Basically, PACs are important because you can have them and be completely asymptomatic, but sometimes you actually can have palpitations. Now we need to determine P wave. Are they there? Yeah, it's there. But you do have some abnormal. So some abnormal P waves. And we've already determined those. Okay, well, what's the next thing? Is there a P for every QRS? Well, here's a P wave, QRS, right? P wave, QRS, P wave, QRS, P wave, QRS, P wave, QRS. Yeah, absolutely. There's definitely a P wave for every QRS complex. So yes, there is definitely AV association here. Sweet deal. Next thing, is the QRS complex wide or is it narrow? I can already tell you right now that if I just look at this right here to this right here, that's 1 and maybe 2 boxes. That's definitely less than 3 boxes, 3 little boxes, I should be specific. So I know that all of these are going to be narrow. So I know that that means that the actual potentials are moving from the AV node into the bundle branch system and there's no aberrant signaling. Okay? All right, sweet. So that's PACs. PACs can cause non-compensatory pauses, which is important when it comes to determining the difference between PACs and PVCs. So remember, PACs, if you just want a little test question note, they do have what's called non-compensatory pauses. We'll get into this in more detail when we talk about the pathophysiology of PACs in another video and how to treat these basically, okay? All right, cool. So we've talked about that PAC. Well, remember I told you that PACs can actually kind of generate a little specific rhythm that you sometimes can see. So let's see if we can find here again. Look at this second EKG here. We're going to go ahead and determine rate. Let's count it. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 times 10 is equal to 120 beats per minute. So it's definitely a little fast. So I'd say that this is definitely a little fast. As you're going to see here, this is definitely irregular. Let's look why. Look at the R-DAR interval here and the R-DAR interval in comparison here. It doesn't take much to see that this is varying. There's definitely a variability between the R-DAR intervals. So this is definitely irregular. Okay, well I know it's irregular. All right, the next thing I gotta do is look at my P waves. Do I have P waves? All right, well let's look here. Here's a P wave here. I can definitely see that one. That one's clear. Here's another very clear P wave. Another very clear P wave. Another very clear P wave, and another very clear P wave. Okay, well what about these QRS complexes here? Where's the P wave? It's kind of like hidden in there. So it's kind of hidden within the structure. It's going to be a part of this. So basically, you know how you have your ST segment and you're going to have your T wave? What happens is it looks like this PAC fired just at the end of the T wave and it fused. So this is kind of a P wave and T wave fusion here. And again, you have a normal P wave. This is again, you have your ST segment, T wave. Looks like the P wave from this ectopic focus fired around the same time. So that's going to be the fusion between the P wave and T wave. And again, you got another P wave. Again, another PT fusion. Another PT fusion, and another PT fusion. So yeah, obviously I can see P waves in some of them, but some of them are abnormal. So there is, yes, there is P waves, but there is some abnormal P waves. Okay. That's definitely something that we know. All right. Can I for sure 100% say that this is definitely a PT fusion? No, but I'm pretty darn sure. I'd say I'm about 90 to 100% sure. The reason why is, again, that QRS complex is coming much, much earlier. So what does that mean to me? That means that that P wave from that ectopic focus within the atria fired before it was supposed to, and it fired at the end of repolarization. And again, it kind of is riding on the shoulders of that T wave. All right. Is there a QRS complex for every P wave, even if it's an abnormal P wave? Again, you follow here. It's an abnormal, but yes, there's a QRS complex. Boom, boom. Yes, there's definitely, as I go through each one of these, there's definitely a QRS for every P wave, okay? So yeah, there is AV association here. Definitely AV association. Next thing we have to determine is the QRS complex is wide or narrow. Again, it doesn't take much to kind of just go about right here and about right here and to count the boxes between. I'd say we're about 1, maybe 2 boxes. Again, less than 3 little boxes. That's definitely a narrow QRS complex. Here's what I want you to kind of see here, because this has a specific type of name. Let's find each PAC. We obviously know that they come early. This one's coming early, okay? So here's a PAC. Then again, there's a pause. This pause right here, again, this is important. This pause right here between this ectopic focus firing and this normal P wave firing, this right here is the non-compensatory pause. That's important. All right. Then we go and we have another PAC firing. Then we have our another non-compensatory pause. Another PAC. Then we have a non-compensatory pause. Okay. And then after that, we have another PAC. Wow, it looks like a PAC is coming every other, right? If I'm correct, it looks like a PAC is coming every other normal QRS complex. So if that's the case, it's coming every other. This is called atrial bigeminy. So bigeminy. Atrial bigeminy is when a PAC is coming after every normal PQRST complex. Okay? So if you look here, here's a PAC, normal, PAC, normal, PAC, normal, PAC, normal, and then again another PAC, and then again another normal one and a PAC. So that's pretty intelligent, right? That's that's atrial bigeminy. All right, let's move on to the next one. So we're going to count off the R waves. 1, 2, 3, 4, 5, 6, 7, 8. Again, this is a 6-second rhythm strip, so we multiply the number of R waves by 10. 8 times 10, 80 beats per minute. That's our rate. It's a simple thing, right? Rhythm. R to R intervals. Are they coming pretty much the same? No. Again, this is definitely a different R to R interval spacing. Yeah, because then you're going short, then you're going long, and then you're going short again. So definitely different R to R intervals, obviously, right? So because there's different R to R intervals on this rhythm strip, this is definitely irregular. All right, cool. P wave, we got to find the P waves. Here's a P wave, P wave, P wave here, 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 P wave here. Do all of these look the same? Absolutely frickin' not. This one definitely is going to look about the same as, I'd say, this one right here. And then we can say this one kind of looks the same as this one here. This one looks different. These two definitely look different. Then these ones definitely look the same together. And then this one looks different. So my P waves, some of them are normal. They're there. Yes, I do have P waves. But again, some are abnormal. Okay, cool. So I know that. Now, P for every QRS. Yes, because look, I'm going here, P, then I have my QRS complex. P, QRS complex. P wave, QRS complex, P wave, QRS complex. And I can just keep tacking away here. P, QRS complex, P, QRS complex. So yeah, there's definitely an association between the atria and the ventricle. So what that means is that even if the SA node is firing, it's going down through your appropriate conduction system. SA node, AV node, bundle of His, right bundle, left bundle, branch, Purkinje. Even if the ectopic focus is firing, it's still going ectopic focus to the AV node, bundle of His, bundle, branches, Purkinje system. So that's nice. QRS complexes, are they wide or narrow? Again, we can just go here and go to about here, and I'm counting the boxes between 1, 2, less than 3 little boxes, that's narrow. Again, look at the pattern here. Here's a PAC, because how do we determine it? It comes early, then it should be. So compare this one to this one. 1 definitely comes before 2, right? Like much, obviously 1 comes before 2. But if you know what I'm talking about here, this R wave is definitely coming a lot sooner than it should be, okay? And look at the P wave. The P wave is definitely, these two are definitely different from one another, okay? So PAC, then we go to a normal P wave, okay? Then we go to a normal P wave, because again, look at our R to R intervals. They're the same. They're about the same here. I could count it up, right? 1, 2, 3, 4. 1, 2, 3, 4. They're about the same. But then look, another PAC. It comes early. And look at that P wave. Look how goofy that thing looks. All right? Then I go again. Normal R to R interval. Normal R to R interval. And again, I got another PAC. How often are the PACs occurring? It's happening every 2. So there's 2 normal PQRS complexes, 2 normal PQRS complexes, and a PAC in between each of those. So that's called atrial trigeminy. So remember that, atrial trigeminy. Okay? So basically, this is what I want you guys to know about PACs. Not to know all of the pathophys and all of that stuff right now. What I want you to understand is with PACs is how to be able to pick them out. They come early and their P wave looks abnormal. Is there a specific pattern to it? Is there a bigeminy pattern? Is there a trigeminy? Sometimes there can even be a quadrigeminy-like pattern. And again, we'll talk about this in more detail when we have an individual video on PACs talking about their pathophys and causes, and we'll get into treatment and diagnostics. But again, I want you to remember that the pause between a PAC and going into a normal P-wave QRS complex, that is called a non-compensatory pause. That is important to remember because that's usually test question kind of stuff. All right, let's move on to the next EKG rhythm, which is going to be our PVCs.
was a good video. Okay, so now I'm going to move to PVCs, premature ventricular contraction. And it looks like there's 4, the bigeminy, trigeminy, and couplets. Okay.
All right, Nisner, so let's go ahead and move on now. We already talked about PACs, premature atrial contractions. Now what we're going to do is we're going to determine how to determine the rate and rhythm for PVCs, so premature ventricular contractions. So how to notice them, how to determine the rate, how to determine if there's a specific pattern to them. All right, so let's imagine, again, just like we saw with the ectopic atrial focus that we saw up and within the atria, there could be some type of irritable focus, right? In the same way, you could have some type of irritable focus within the ventricles. And this little dude, he can be a little agitated. What can agitate this ventricular focus? So let's say here's our ectopic focus, right? So there's a little irritated tissue. What irritates this little dude? It could be hypoxia, right? So obviously low oxygen within the blood, whether that be because our red blood cells are decreasing, so it's anemia, whether it be due to some type of lung issue, like COPD, asthma, pneumonia, pneumothorax, who knows? Or whether it be due to a decrease in cardiac output, maybe congestive heart failure, cardiogenic shock, obstructive shock, something like that where you're not getting enough oxygen flowing through the blood for whatever reason. That can cause this little dude to become irritated and to fire action potentials off. Okay, what else? It could be due to electrolyte abnormalities. So sometimes certain types of electrolytes, maybe potassium, maybe calcium. Sometimes as there's fluctuations within these cations, there can be agitation to these cells and they can fire, okay, undesirably. It could also be due to increased sympathetic nervous system activity. So anything that really increases your sympathetic nervous system, so your flight or flight system, right? And that's going to increase your epinephrine and norepinephrine activity on those beta adrenergic receptors, right? And that's going to agitate those dudes. What else could it be? It also could be stimulants. So in the same way, these are sympathomimetic. This could be due to cocaine, right? So cocaine, it could be due to ADHD medications like methylphenidate or methamphetamines. It could be multiple different things, right? But basically, this is one of the reasons why these little irritable focuses can actually fire off these action potentials. Another reason, we didn't talk about it with the atria, but to kind of go off of it, it could also be due to infarcted tissue, or another way we can kind of say this is scar tissue. So let me explain what I mean by this. Let's say here in the myocardium, there's this little infarcted tissue right there, right? And it's trying to, basically you want to conduct action potentials. And so here's this action potential moving along the ventricles, right? So it went up the bundle, down the bundle branches, it's going through the Purkinje system, and it encounters this infarcted tissue. Well, it can't go through it because this infarcted tissue doesn't conduct action potential, so it has to go around it. What happens is, whenever this kind of stuff happens, it can create a reentrant circuit. And these reentrant circuits can actually kind of let action potentials flow off of them and generate heart rates that are extremely high. And this is what can make it very dangerous. So one thing I want you to remember is these can create what's called reentrant circuits. And again, we'll get into more detail in this when we get into the more pathophysiology of this stuff. Just introducing you to this stuff. All right, cool. So we got kind of an idea of what the heck these PVCs are, what triggers them, and basically how they're generating these things. All right, let's go ahead and knock these things out then. What do we do? Rate. Let's count all the R waves or S waves in this case. Here's an R wave. This is an S wave. Okay? R wave, S wave, R wave, S wave, R wave, S wave, and again an R wave. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9. So it's going to be 9. This is a 6-second rhythm strip, so you multiply it by 10. That's equal to 90 beats per minute. Okay? So that's going to be the rate on this dude. All right, next thing we do. we determine the R to R interval, okay? With this situation here, again, you're kind of going off of this, this PVC here. So let's imagine here, we kind of take it from this point here, and we go to this guy. So 1, 2, maybe a half. Then we go to the next one. So we're going to go to this point about here. So we're going to have 1, 2, 3. Ooh, it's already off, right? So that's definitely off. We move to the next one. You go from here. You got 1, 2, and you got about a half. Then you got 1, 2, 3, and again, I got about a half here as well, okay? So we're definitely throwing kind of a irregular R to R interval here, or we can actually say R to S, and then again, R to S interval here. But again, we're kind of showing the same kind of thing here as you move along. This is definitely irregular in nature. So we have an irregular rhythm here. All right, so let's go ahead and move on here. So do we see P waves? P waves, here's a P wave, but then before the QRS complex, is there a P wave? I don't really see one. Okay, it might not be a P wave there. Here's another P wave. I can't really see a P wave here before this QRS complex. There's a P wave there. Again, I don't really see a P wave here before this QRS complex. P wave. Okay, so as it seems here, there is some P waves. But again, if we kind of follow this, and this kind of answers our next question here, there's not a P wave for every QRS. There is for these normal ones, but whenever we get to these abnormal like PVCs, there's no P wave. So there is some AV dissociation here. Dissociation. Okay, and again, why is that? Is because I don't really see a P wave before we're going into the QRS complexes for these PVCs. Okay, so that's an important thing to realize. All right, cool. What about the QRS complexes? Are these suckers wide or narrow? Remember, PVCs, these things are firing from these little these ectopic areas. There could be a reentrant circuit or it could be an irritable ectopic focus. When they fire, they're not going to go through your normal bundle branch system, right? So they're not going to be going from the SA node. They're not going to be going through the AV node. It's not going to be going through the bundle of His and then to the right bundle branch and left bundle branch. It's going to be traveling in an abnormal way. So because of that, let's go ahead and take here, this point here, and we're going to go to about this point here. And we're going to count the boxes. So 1, 2, 3, I'm at about 4 boxes. So if I'm at around 4 boxes, maybe 3 or 4 boxes, little boxes, that is obviously a wide QRS complex. So these suckers are definitely wide. And again, I could try to do another one over here, about there, to about there, and again, 1, 2, 3, and again, about 4. So about 4 little boxes, that's definitely going to be greater than or equal to 3 little boxes. So this is definitely a wide QRS complex. Now this should be something that you need to remember. The wide QRS complex is because these PVCs that we see, this one right here, this is our PVC, this is a PVC, they're not going through your normal conduction system. They're coming from either an irritable focus or from a reentrant circuit, and they're not going through your normal conduction system. If they don't go through the normal conduction system, in other words, SA node to AV node to the bundle of His, I want to put BH there, to the bundle branches, to your Purkinjes, then it's not going to have that normal narrow QRS complex. So if it's coming from some other site, this ventricular focus or this reentrant circuit here, it's going to generate these wide and abnormally appearing QRS complexes. Okay? So remember that this is an abnormal QRS complex that's wide. That's because it's not coming from this normal conduction system here. All right, so before I move on to this next EKG, remember I told you guys that this is weird, that these QRS waves are actually going to be like negative in deflection? Go back to the basics. Remember, this is lead 2. Negative electrode here, positive electrode here, right? And then we create like this kind of axis of this lead. Remember, the QRS vector, the mean, you want it to point towards the positive electrode. Well, what if in this case, this ectopic focus is firing, and when it fires, it actually, usually, if it's firing, it might be firing this way, from the left ventricle moving over into the right ventricle. And so it might actually be moving and towards the right ventricle away from this positive electrode. If it's moving, this positive charge is moving from the left ventricle towards the right ventricle away from the positive electrode, what kind of deflection do you get? You should get a negative deflection. So again, that's one thing if you really are interested in, you can determine if an ectopic focus, where it is based upon the direction of the QRS complexes. Look at your leads. Use that basic stuff that we talked about to determine your vectors and which way they are pointing in association with your lead. So according to lead 2, this most likely is going to be an ectopic focus in your left ventricle moving towards the right ventricle. Okay? And maybe even kind of lower within the ventricles as well. All right? So let's move on to the next EKG here. All right, so for the next EKG, let's count up our rate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 times 10 is 120 beats per minute. That's our rate. Let's go ahead and determine our R to R intervals. Oh my gosh, we don't even have to keep going here. It's obviously all fricked up. Okay, so this is definitely not a regular R to R intervals. They're all jacked up. So this is definitely irregular. This is super obvious, okay? Next, go to the P waves. Are they normal? Do you have P waves? Here's a P wave. Okay, this is a T wave here. I don't really see my P wave at all. There's no P wave. If it is, maybe it's kind of hidden within my QRS complex. It might be like hidden in here, but I don't see it. Okay, so no P wave there. Then I go again, and I'm going to have another P wave, a normal one. Then I have a T wave. Then I have another P wave. Okay, cool. QRS complex. And then again, I go over here, I got a T wave, and oh, I don't see a P wave again. All right. Well, remember I told you, anytime you see these wide QRS complexes, and they're coming early, so this is definitely coming earlier than it should, and it doesn't look like a normal QRS complex, in other words, it's really wide, and it's abnormal appearing, this is a PVC. That's a PVC. This is a PVC. That's a PVC. Huh. Well, these PVCs seem to be coming after every 2 normal PQRS complexes, right? So if it's coming after every 2, this is called ventricular trigeminy. Well, let's go up for a second to that one that we just did before. Let's look at this son of a gun. We have a PVC, and it's occurring in between each normal PQRS complex. We call that ventricular bigeminy. It's the same concept as before. All right, cool. We know that we have wide QRS complexes, right? And these are definitely our PVCs, and it's definitely irregular. We have some P waves, but some P waves aren't there. So there's some P waves. And because some P waves aren't there, in other words, there's not a P wave for every QRS complex, there's no AV association. So this is AV dissociation. Next thing, QRS complexes. Are these suckers wide or narrow? This is obviously a wide QRS complex. Okay? And again, we determined that the PVCs have a very specific pattern to them. They're occurring after every 2 normal PQRS complexes, PQRST complexes. Okay? So ventricular trigeminy, if it's after every normal PQRST complex, it's ventricular bigeminy. All right? We have here, let's count up our guy here. 1, 2, 3, 4, 5, 6, 7, 8. 8 times 10 equals 80. 80 beats per minute. All right, R to R interval. Look at that. And look at this. Oh my gosh. This thing's all over the place, right? There's no consistency in these R to R intervals. All right, there might be some consistency here and here, but between this one and this one, there's no consistency. Between this one and this one, there's no consistency. So this is definitely irregular. All right, cool. P wave, do we got a P wave? We got a P wave here. We got a P wave here. I don't see a P wave before that QRS complex. I don't really see another P wave before that QRS complex. I don't see another P wave before that QRS complex. Okay, again, there's some P waves and then some of them are not there. So we're going to put some P waves. So because of that, because there's not a P wave for every QRS complex, what does that mean? Is there association between the atria and the ventricles every single time? No. So there is some AV dissociation. Now here's what I want you to remember. AV dissociation means that there's, again, not every action potential is going through the AV node into the ventricles. All right, so it's not going SA node all the way down to Purkinje's. And again, that is why you're getting these little PVC. So I got a PVC here, a PVC here, and a PVC here. And it happens 3 in a row. Now here's the thing. PVCs can cause palpitations, right? And sometimes we're going to get to another rhythm, which we're going to talk about. This son of a gun looks a lot like something called VTAC. So whenever you have something that is, again, look at the R to R interval here. Is it about the same? Yeah. So what would you call this? It's 1, 2, 1, 2. If something is about the same R to R interval, what is that? It's regular. If you have something that is actually regular and wide QRS complexes, but it's moving at a very fast rate, what would we say our rate is here? Well, it's going to be 300 and 150. Anything greater than 100 is tachycardic. So this is wide complex tachycardia. But we say whenever you have more than, greater than, or equal to 3 PVCs, this is now VTAC. And VTAC is pathological. So you can have PVCs, and PVCs can be completely normal. It could just be because you had too much caffeine, you had a little bit too much coffee, or maybe you're taking your ADHD medication. It's increasing your heart rate, right? So it's causing an increase in sympathetic activity. So these can be completely normal. But whenever you have 3 of these in a row, it is now considered to be pathological, and we call it VTAC. There's actually a special name for this one. They actually call it a 3-beat salvo. Sometimes they call it a PVC triplet. But again, this is basically considered to be pathological. So whenever you have 3 or more PVCs in a row, it's considered to be VTAC. And we'll talk a little bit more about that later. So again, what's our QRS complexes here? Wide. We already kind of talked about this. How it was wide complex, regular in interval, regular rhythm, and tachycardic. And we call that VTAC. And these all look the same. That's another thing. If your PVCs all look the same, that means it's coming from one ectopic focus. So only one irritable cell in the ventricles is firing. If you have some that are different in appearance, so in other words, let's say that this one was pointing upwards, but had another one that was this one was pointing downwards, then that would be a different type, right? So this would be another ectopic focus. And sometimes we can call that polymorphic. And we'll talk about a specific type of polymorphic VTAC in a little called torsades de points, which is a very dangerous one. Okay? So again, in this, what I want you guys to be able to recognize is how to find PVCs, how to find PACs on the EKG, how to determine if those PVCs and PACs have a particular pattern. In other words, is it bigeminy or is it trigeminy? And most importantly, do I see 3 or more PVCs in a row? If I do, this is now considered VTAC, and that could be a medical emergency. I hope it made sense. I hope you guys really did like it and enjoy it. If you guys did, hit that like button, comment down in the comments section, and please subscribe. Also, if you guys want, go down in our description box. We have links to our Facebook, our Instagram, even our Patreon account. If you guys have the opportunity and you would like to donate even $1, we would truly appreciate that. Helps us to continue to make videos for you guys' enjoyment. In the next video, what we're going to do is we're going to talk some more about how to determine the rate and rhythm for EKGs representing things like torsades de points, how to determine if something is VTAC, and how to determine if someone is in VFib, and we'll talk about what you do in those scenarios. Okay? So again, as always, Ninja Nerds, we love you, and until next time.
That was a really good video. I like him.
Complexes, so let's talk about those. Again, if you recall, whenever we're looking at ectopic beats, first we want to analyze the underlying rhythm. So if we're looking at the underlying rhythm here, where am I now? So here we have a QRS that falls in a dark line. The heart rate here is 300, 150, 100, 75, 60. The difference between 75 and 60 is 15, divided by 5 is 3, so that's 63, 66, 69 roughly. So the heart rate is 69 beats per minute roughly, and it's a sinus rhythm underlying, so we have a normal sinus rhythm, and then we have this funny looking beat here. which I'll talk about. So heart rate and the underlying rhythm may vary, and may be normal, may be fast, may be slow. Where there's a premature ventricular complex, there's no P wave preceding the PVC. So you notice that there's no P wave here. This is actually a T wave here, so we don't see any P wave there. And the peer interval where the PVC is concerned is not applicable. And the QRS is wide and bizarre, and that's key, right? The QRS has to be at least 0.12 second or greater. The QRS of a PVC will be at least 0.12, but is usually 0.14 second or greater. And with this wide and bizarre QRS, the beginning of the QRS starts about here, and the end of it is roughly there. So this is probably the T wave here, or the ventricular repolarization phase. But in any case, just by looking at it, we can see this is a wide QRS. There's probably no great need to measure it in detail. And the ratio of P waves to QRS is applicable in the underlying rhythm, but in the PVC it's not applicable. And the rhythm is regular except where disrupted by the PVC or PVCs. The exception would be a patient who has an underlying rhythm of atrial fib, which is normally irregularly irregular, and if they have PVCs thrown in there, then it would be an underlying irregular rhythm. Now, one of the things I wanted to mention about premature ventricular complexes is in this particular case, you can tell clearly that this is a ventricular beat for a number of reasons. One, because it's wide and bizarre. Two, because there are no P waves. But if you think about how we monitor patients, normally in lead 2 we have a positive electrode here, and in the underlying beats we can see the QRS is positively deflected, and that's because the wave of depolarization moves towards the positive electrode, so you get a positive QRS. But in the case of the PVC, if we move that over here, if you have a focus down here and the wave of depolarization is moving away from this positive electrode, then we get this negatively deflected QRS. So we know this focus is depolarizing in the opposite direction of these underlying beats. So that's just additional evidence that we're dealing with a PVC here. The other thing is worth mentioning is that you'll sometimes hear people talk about a compensatory pause following a PVC. Now, compensatory pause means that if you map out the R to R waves, then the distance between the beat preceding the PVC and the beat after the PVC is equal to exactly 2 cycles, and they call that a compensatory pause. So most PVCs you'll see a compensatory pause, but I wouldn't hang your hat on the compensatory pause because not all PVCs have a compensatory pause, and sometimes you'll see PACs with a compensatory pause.
The heart has 2 lower chambers, called the ventricles. So a premature ventricular contraction is when the ventricles contract earlier than normal in the cardiac cycle. This happens because an abnormal contraction signal, called a depolarization, originates from somewhere in the ventricles, rather than coming from the pacemaker cells. So if we simplify this heart a little bit, normally the sinoatrial or SA node sends an electrical signal that propagates out through the walls of the heart and contracts both upper chambers. Then that signal moves to the atrioventricular or AV node, where the signal is delayed for a split second. And then it goes down into the ventricles or lower chambers, where it moves down the bundle of His into the left and right bundle branches, and into each ventricle's Purkinje fibers, causing them to contract as well. So in a healthy heart, the upper chambers contract first, then shortly after the lower chambers contract. On an electrocardiogram, or ECG, which measures the electrical activity of the heart via electrodes that are placed on the skin, the atrial depolarization, and therefore its contraction, is seen as a P wave. The ventricular contraction is seen as a QRS complex, and the ventricular repolarization, and therefore its relaxation, is seen as a T wave. This empty space here is called the PR segment, and it corresponds to the pause in the AV node. And this one is called the ST segment, and it corresponds to the interval between ventricular depolarization and repolarization. And this one's called a TP segment, which represents the heart's quiet time when the cells are finished repolarizing and are ready for another signal. Now, if we just look at the QRS complex, which normally lasts less than 100 milliseconds or 2.5 little boxes, it's usually made up of 3 smaller waves, also called deflections. If the first wave after the P wave is downwards or negative, it's called a Q wave, which you can remember by the letter Q having a downward tail. If the next deflection is upward or positive, then it's called an R wave. If, though, the first wave after the P wave is upwards instead, or positive, you basically skip the Q and just call it an R wave. Finally, any downward deflection after the R wave is called the S wave. Now, the interesting thing is that in addition to the pacemaker cells in the SA node, cells in the AV node, the bundle of His, and the Purkinje fibers all have the ability to generate an electrical potential. Those last 3 are called latent pacemakers, and they have slower depolarization rates, which is the rate at which they fire off electrical signals, and they get slower as you move further down. Let's use this bar to visualize the SA node's depolarization rate, which is the fastest, and then each one below is slightly slower. Notice that each time the SA node fires, it resets all the slower ones. And this is exactly how it works. If, for example, the SA node stopped altogether, then the AV node would take over at its slightly slower pace. Now though, let's say you have a ventricular ectopic focus somewhere in the ventricles, which is a cell or area of tissue that sends off an early depolarization wave, before even the SA node gets to fire. This is what leads to a premature ventricular contraction, or PVC. One cause of a latent pacemaker cell or cardiac muscle cell depolarizing early is it gets enhanced automaticity, which might result from irritating stressors like electrolyte imbalances, drugs like cocaine or methamphetamines, ischemic damage like a heart attack, or anything that increases sympathetic activity, like anxiety. Ectopic beats can also have triggered activity, which is where cells depolarize early. The exact mechanism here, though, is unclear, but it might be due to an ion channel dysfunction that leads to an unexpected change in the membrane potential during or right after repolarization. When a cell depolarization happens during ventricular repolarization, it's called an early after depolarization. And if it happens after repolarization is finished, it's called a delayed after depolarization. A final type of ventricular ectopic focus is a reentrant loop, where a depolarization wave encounters tissue that doesn't depolarize, which could be something like scar tissue after a heart attack. And as a result, the wave starts going around and around that tissue, forming what's called a reentrant loop. A reentrant loop basically starts sending out depolarization waves to the rest of the heart tissue each time the wave goes around. If the ectopic focus originates in the right ventricle, the wave will depolarize the right ventricle first and then the left ventricle. And this produces a QRS complex that looks like a left bundle branch block. If the ectopic focus originates in the left ventricle, the wave will depolarize the left ventricle first and then the right ventricle, which produces a QRS complex that looks like a right bundle branch block. Now, lead V1 on an ECG measures a depolarization wave that moves toward the right ventricle. So when an ectopic focus originates in the left ventricle and moves toward the right ventricle, the V1 lead shows a large positive complex, with a dominating R wave. When an ectopic focus originates in the right ventricle and then moves toward the left ventricle, the V1 lead shows a large negative complex, with a dominating S wave. Regardless of the originating ventricle, a premature ventricular contraction often has an abnormal T wave, since the timing and direction of repolarization will be abnormal as well. Alright, so let's say that the heart's cruising along at about 60 beats per minute, which means that there's 1 second between P waves and QRS complexes. All of a sudden, an ectopic focus in the ventricles fires off, which contracts the ventricles, and that wave of depolarization tries to travel up to the atrium. But since this happens so close to the previous depolarization, the atrium's still in its refractory period, so the wave gets stopped at the AV node. A split second later, the ventricle enters its refractory period. Since the sinus node's going at 1 beat per second, and it's out of refractory, it fires off a signal and the atria contracts and you get another P wave, which is right on schedule. But this time the opposite thing happens, and the ventricle's in refractory, so it doesn't contract. Now both relax and come out of refractory, and exactly 1 second later the sinus node sends another signal and the atrium contracts as it should, and then everything carries on as per usual. This situation is called a compensatory pause, which is defined as having a normal sinus complex landing exactly 2 times the normal sinus interval, which was 1 second, so 1 times 2 equals 2 seconds. What ends up happening here is there's this big long pause between ventricular contractions, which is greater than the sinus interval. Longer time between contractions means more ventricular filling, which means the heart contracts with greater strength, which can be felt as a palpitation. Alright, now let's run a slightly different scenario, one where the PVC comes a little bit later, after the atrium comes out of refractory. In this case, the wave of depolarization makes it into the atrium and depolarizes the atrium, including the sinus node. So essentially the sinus node resets about 4.4 boxes from the last, or 0.88 seconds. In this case, after being depolarized, the sinus node waits its 1 second, and then sends another signal, and again we carry on as normal. This time we call this a non-compensatory pause, because the sinus complex lands less than 2 times the normal sinus interval. And this is how you can tell if the PVC depolarized the atrium or not. A ventricular ectopic focus can fire at different points in the cardiac cycle, which we can look at using the ECG. First off, it might happen during a P wave, which can get completely lost in the QRS complex, but can sometimes be seen if you search for it. Next, the ectopic beat could happen during the PR segment, and because the ectopic depolarization happens relatively slowly, oftentimes it will combine with a normal depolarization wave coming down the ventricular conduction system, resulting in a ventricular fusion beat. These can appear lots of different ways, depending on where the 2 depolarization waves meet each other. Early after depolarizations might start during the ST segment, or even during the T wave, which is called R on T phenomenon. This used to be considered an ominous sign of an impending dangerous arrhythmia, but recent studies show that this might be a bit more unclear than once thought. Sometimes premature ventricular contractions can keep happening, rather than be isolated events. For example, ventricular bigeminy is when a premature ventricular contraction consistently comes after each normal cardiac cycle. Ventricular trigeminy, on the other hand, is when one consistently comes after every 2 normal cardiac cycles. Also, you might have multiple ectopic foci firing off PVCs, which end up producing different appearing QRS complexes on a single rhythm strip. Now, most people with premature ventricular contractions don't notice them, but if they keep happening, they can cause lightheadedness because of less blood getting delivered to the brain. In rare situations, an ectopic focus can trigger ventricular tachycardia, or even ventricular fibrillation, which are both serious arrhythmias where the ventricles beat too quickly to fill up with an adequate amount of blood. The diagnosis of a premature ventricular contraction is based on an ECG, but sometimes a Holter monitor, which is like a continuous ECG monitor used over a few days, is needed to capture the event. Typically, premature ventricular contractions don't need treatment, and if there's an obvious cause like a medication or a use of a substance, then stopping that typically resolves the issue. If the premature ventricular contractions keep happening or cause palpitations, they can be treated with beta blockers or calcium channel blockers, both of which prevent the heart from beating too strongly. If an ectopic focus is triggering ventricular arrhythmias, radiofrequency ablation can be done, which is where radiofrequency waves are used to destroy the tissue that's causing the ectopic heartbeat. Alright, as a quick recap. Premature ventricular contractions are abnormal heartbeats that originate in the ventricles, and show up as tall and wide QRS complexes on an ECG. They can be caused by abnormal automaticity, re-entry, or a triggered after depolarization. They're usually asymptomatic, but when they're a sign of an underlying disorder, treatment including a radiofrequency ablation might be necessary.
Hey guys, Vince here. So I actually didn't have anything to do with this video. It's one of Tanner's. He's on a much-deserved vacation right now, and he'll be back next week. Anyway, Tanner always does a really spectacular job explaining the cardiovascular stuff, so I hope that today's video was useful to you. Of course, he didn't act alone. Today's script was written by Charles Davis and Tanner. It was edited by Risha Desai. Tanner created the illustrations and performed the voiceover, and Yip Font did the video editing. If you'd like to support the creation of more of these kinds of videos, I encourage you to check us out at osmosis.org.
Okay, so none of those videos talked about couplets, but so I'm assuming that, and I couldn't find a video on couplet, but I'm assuming that that means there's two identical ones right after the other. So I'm going to end the video here and do another video on multifocal or multiform PVCs. Right on T, PVC, a first degree AV block, Winkelbach rhythm, second degree type 2, third degree AV block, and bundle branch block on the next video. And that should do really good for, that takes up to the UF lecture. I'm not really using the UF lecture that much. The YouTube videos are really working for me. Anyway, so let's stop here and catch you on the next one.